Welcome to the Mental Health Boot Camp Podcast, where
Hello.
the podcast where 4 psychotherapists, 3 from Canada, 1 from the United States, serve you cutting-edge mental health knowledge. I am Dr. Ryan Howes from Pasadena, California.
And I'm Dr. Brooke Lewis from Vancouver, Canada.
I'm Chris Boyd, also from Vancouver, Canada.
And I'm Joanna Boyd from Vancouver, Canada, and Chris's younger sister.
Yes, indeed.
Mm-hmm.
Welcome, everybody. Welcome to late October and Halloween season. Holidays are among us. I guess cold weather is actually coming to you guys, which is interesting.
It is.
Yeah, so there's an Arctic wind or something coming down through BC. So most of the southern BC is under a snowfall warning for right now. So up to, let's say, between 3 to 7 or 8 inches of snow.
Wow.
Really?
Like-
In Vancouver as well?
Vancouver's kind of right on the outskirts. It may or may not snow in Vancouver, but so in Whistler, where we're gonna go, they're like 3 inches, maybe. But then when you're getting into like the mountain passes and stuff, then that's gonna be more like 8 inches of snow.
Do you have your snow tires on?
I do.
Okay, good. Those are needed now. Whew.
Whew. Never took them off.
There's certain highways up here in Canada that are required to have snow tires. Otherwise, you can get ticketed.
Yeah,
If
from
you're-
October 1st till March 31st.
Wow. Okay. Well, we are in that, we're falling in that season, so drive safe.
I have a serious question for you all. What's your favorite Halloween candy?
Wow. It's not candy corn. I'm not into those little waxy bits there. They don't really do it for me.
Tootsie Roll is one of my favorite.
What? No way.
I
That
think
is a good one.
I just especially, you get their little ones or the ones that are a bit of a bigger log or whatever they are.
Yeah.
And then the little flavored ones like you got in that boot, Brooke, that you got. And then just a good old
Wait, hold on. Brooke ordered a pair of boots, and the people sending the boots put a little bag of candy in the left boot, and Brooke thought that was adorable, right?
Yeah, it brought me so much joy. Yeah, it was so good. So good. Well done. Shoes for the soul, Nelson, BC. Well done.
Oh, a shout out, a plug.
Yeah,
It's great.
a big old plug.
You get candy in that right boot next time.
I hope so.
So, okay, so we got Tootsie Rolls.
Roll.
or like the little Smarties. Those would be my go-tos.
Who are you?
You know, I have a feeling Brooke is asking this question because every time I walk in a grocery store, there's all these different boxes and mixtures of chocolate. So I usually eat a tremendous amount of it before Halloween gets here. But I like the up here in Canada, we have a box that has like the arrow in it, the Smarties and the
Kit Kat
Kats.
and Coffee Crisp.
And Coffee Crisp, yeah. Like the bento box, the mixture of chocolate.
So good.
Coffee Crisp. I don't even know of Coffee Crisp. Wow. Okay.
Delicious.
Does it taste
It's
like coffee?
It's like a wafery.
Wafered, yeah, dipped in chocolate, and it's a little coffee flavored. So it's
Interesting.
Mm-hmm.
Okay. I'm just a sucker for the old, the mini Three Musketeers, Milky Ways, Snickers bars. Those little guys.
Nice.
Oh yeah.
They're my go-to.
Yeah,
Those are
that's
the
good.
ones I steal from my kids' bags when they come back from trick-or-treating. We call it the dad tax.
Oh yeah, I've taken an anti-tax before too.
I'm sure they're thrilled. Like, take them, Tootsie Rolls. You can have them. Or least favorite candy.
Tootsie Rolls are probably really understated. Like, I think they're the winner of Halloween, really.
Oh, is that for you too? Is
No,
that
I
your
don't.
favorite?
I think I've eaten a lot of Tootsie Rolls. I'm not going to turn a Tootsie Roll down, but like the fact that I think they're gluten-free and they're dairy free. There should be more Tootsie Rolls.
I just don't, they just seem to be the most like manufactured. You're just like, what am I eating? But it's so good.
Well, it's kind of like saltwater taffy. It's like I don't know. I don't even know what a Tootsie Roll is composed of. Is it like malt?
I don't know.
It's just Tootsie rolled up. No,
It's just
Tootsie.
some sugar concoction.
So what's yours, Brooke?
I think it's like the mini Reese's peanut butter cups, but not the ones that are in the shape of the peanut butter cup. They're like even smaller than that. They're like a thimble one, you know?
Oh yeah.
Like
Okay.
I don't know why. I'm guessing it's the peanut butter chocolate ratio. However, if I were to have one today, I'd be like, there's way too much sugar in it. I don't know. I might go back to Tootsie Rolls later.
Well, now you're making me think of Reese's Pieces, like the actual, like the things like E.T. likes, the little Reese's Pieces.
Yeah.
Those, I love Reese's Pieces.
yeah. I'm gonna switch mine to a juice box. You guys ever get a juice box?
No.
Oh, no.
It'd be the can of pop.
Yeah. Or like the little Snickers. Those are good.
Yeah.
Because the peanuts in them. I like those.
Oh yeah. You can start to think that it's healthy. Well, it's nuts.
Almost.
Those are good for you. Yeah.
Pretty much a protein bar.
That is good. Everybody out there, if you're interested, please send us your favorite Halloween candy at info@mentalhealthbootcamp.com. We'll take a survey. We'll report the results next week. Okay, enough of that. So we do this little thing here that we call an ambush. And an ambush is when one of us comes up with a topic, the other three don't know what it is, and we try to answer some questions, describe it, and talk about it a little bit. A mental health related topic, right? So this week, Brooke is up, and we get to hear from her. Brooke always has some zingers, so we'll see what this one's like this week, huh?
It's not always a zinger. Like sleep hygiene.
That was a snoozy.
Snoozy. Oh, that was good. All right, sending.
Okay. All right, it's coming my
On
way.
that one, Chris.
Going all the way down there to California.
Oh boy.
Oh, great.
That's a good sign.
I mean, woo, can't wait to hear it.
Yes.
It's
I
more
don't
than
know.
2 words this time.
Let's see if we're how qualified we are to answer this question. Ready? Okay. Medication. What are the common myths or misconceptions? Do you think medication is helpful? And if so, when? And if you feel medication is unhelpful, why? Okay, we got some digging in to do here. Medication, I'm assuming here you're talking about psychiatric medications, right?
Yeah, psychotropics. Just because I think it comes up a decent amount in my clients.
Mm-hmm.
Well, they'll come into the session and they're going to ask my opinion on it. Like,
yeah.
Do you think medication's helpful? Do you think I should be on medication? What medication? So obviously there's a lot of boundaries around that. We cannot suggest certain medications to clients. That is definitely out of our scope, but we have some knowledge about what they are, what they do, studies of if they're effective or not. But I'm noticing that there is more and more controversy in the past 5-10 years, and not because people are thinking like for or against it on their belief level, but more from research. More and more research is coming out, or people are disclosing more research that are making us ask more questions. So I thought it would be good a conversation.
It is. And let me just clarify from the beginning for some people who may not be familiar. One of the most common questions that I get when I tell people I'm a psychologist is to say, "Oh, do you prescribe medication?" And just to throw it out there, psychologists and psychotherapists in general do not prescribe medication. That's not our thing. We weren't trained for that medically. But psychiatrists are medical doctors, and they are the ones who typically prescribe medication. Although nowadays more and more kind of primary care physicians, family doctors are prescribing medications, anxiety medication and depression medication, especially. So we take classes on learning about medication, and we have continuing education workshops and things about medication, but it's mostly to inform us and kind of help us to be aware of when we might want to refer someone for medication, that sort of thing. But we don't actually do the prescribing.
And I'm glad you brought that up. So that would kind of go into the first part, misconceptions.
Yes,
A
there
lot
you go.
of people don't realize that we're not able to do that, and why
Right.
we're not able to do that.
Yes. Extra little caveat on that. There's a movement in the States here for psychologists to be able to prescribe, and there are actually several states now that do offer prescription privileges for psychologists. They have to go through extra training in order to do that. But there's some people who think that's a great idea. Some people think, no, let's not do that. Let's just keep it pure to psychotherapy. But anyway, just throwing that out there to confuse things a little bit more.
Perfect.
Yeah.
So there's more myths and misconceptions about medication. There's a lot.
Yeah. I think it's tricky because when it comes to something like mental health, often people think it follows a medical model where you can take a medication or a treatment and that's going to solve the underlying issues. And from my perspective, yes, it can be part of the treatment plan, but often maybe doesn't address the underlying concerns or issues that need to be explored with psychotherapy. So in some circumstances, maybe the combination of medication and psychotherapy could be useful.
Right.
I've also noticed how subjective it can be based on the individual. So some people come in and feel that was really helpful in terms of assisting them with the symptoms of depression or anxiety, whatever it might be, where others have had really bad experiences taking it. Again, I don't, in counseling, I don't give my perspective on it too much. It's, usually refer them to their medical doctor or psychiatrist to learn more or assess the effectiveness of it.
Many years ago, I wrote an article in Psychology Today called 4 Things Medication Can't Teach You, which had to do with, medication can be helpful in improving symptoms. It can definitely help people improve their functioning. Maybe it raises their depression or lowers their anxiety. It definitely has some benefits, but it's not going to tell you why you feel that way in the first place. It's not going to tell you why you're depressed or anxious, because medication doesn't teach you these things. Medication doesn't teach you what else you can do to help with the symptoms, just medication alone, right? Because there are many other behavioral things that people can do to manage their symptoms of, say, depression or anxiety. It won't teach you how to keep something from recurring in the future, right? Let's say it lifts you out of a depression, and then you say, okay, I'm done now, so I'm going to go off it. It's not really teaching you anything about how to avoid future depression, right? And it doesn't teach you who you are. This is just kind of my pitch for psychotherapy there. You're not really going to learn much about yourself necessarily just from medication alone. You have to do some more self-exploration. So that's kind of my caveat that I'll tell clients if they're thinking of going on medication. Saying, yes, okay, if that's where we are, absolutely. But let's remember that that's only part of the picture. It's probably going to help, or could possibly help you with symptom management, but it's not going to, that medication alone is not going to teach you anything.
For sure. We had a psychologist that Joanna Brooke and I knew very well, the late Tina Colton. She was fantastic and a mentor for us. And she had a great way of explaining medication to her clients. She talked about the window of tolerance and how on either end is rigidity or chaos, right? So the goal is to have a nice range of emotion in the middle there, kind of influenced by the Dan Siegel window of tolerance there. But sometimes you dip down or you dip up, and again, you have a hard time functioning or things are very chaotic. So it can help you get you back into that window. But after that, maybe that's where the psychotherapy or the other approaches can help, right? So kind of highlighting the functionality piece their being able to function that you talked about there, Ryan.
Sure.
I like, Ryan, your comparison there or you noting that medication won't help you necessarily discover or with the root cause or what's happening, right? I think
Sure.
about that just with medication for a different kind, just for bodily ailments. If you have an ache or pain, you can take a Tylenol or Advil to help deal with that, but there could be something that keeps happening that's giving you that pain. And if you're not going to figure that out, you're not really there's better ways to maybe help yourself. Not better ways, just more to explore than medication alone could do for you.
For sure. Yeah. And there's different types of medications, psychotropic medications that are often prescribed, like the SSRIs that are often used for depression and sadness and sometimes anxiety. There's also benzodiazepine, which is a little more of an intensive medication that if you're on it for a while, it can, it's almost like a mild tranquilizer, isn't it?
Sure.
The feeling it provides you, but can be, if longer on it, you may have to wean yourself off of it. It can impact your ability to focus your mind.
Now, I also want to be fair. I don't want us to slip into a place where it sounds like we're bashing medication, because I've got to say I've seen some clients who benefited greatly from medication. Where we worked for a while trying to help teach them why they're feeling that way and kind of discover some different things they could do. And then they say, all right, I'm going to try medication now. And it's like a light switch. For some people, it could be pretty remarkable. Within a few weeks, they feel a lot better. They're coping a lot better. Mm-hmm. And it can be a great thing. And can actually help enhance the psychotherapy because they're better able to take some things in, or they can think more clearly, or whatever that might be. Mm-hmm. So definitely don't want this to come across as anti-medication, because there's and in fact, I would say one of the myths that I would like to throw out there too is that taking medication means that you are severely ill, or that you're going to be hooked on it for the rest of your life. And certainly there are some folks who can get maybe on some of the benzodiazepines, the Xanax or something like that. Some people can get really can get hooked on those if they're not watching the medication closely. But for most people, it's a temporary thing. They'll take an SSRI for a few months or maybe a couple of years, whatever that might be, under the close supervision of a physician, and they are hopefully feeling better and kind of building up a scaffolding beneath them so that they're not going to fall back into depression when they come off, and they can wean off the medication and it's fine. So I don't think there's anything morally or characterologically wrong with somebody who takes medication. And of course, the analogies that we all like to use are things like, if you have diabetes, you'll take insulin. If you have
asthma, you'll take a puffer.
Mm-hmm. Yes, sure you will. All sorts of different ailments that people will take medication for, and it's shown to be helpful. There's no need to have a stigma about psychiatric medication.
Definitely.
So, Ryan, before you went into those myths, I picked up on another myth you touched on without realizing it that I've heard from clients, which is, or a misconception perhaps, that it's going to start working right away.
Yes.
That they're going to go to the doctor, they're going to get this medication, an SSRI, and they're going to feel better like in a day or two. And so that's an educational, a psycho-ed opportunity often in therapy for me, is letting people know this is a gradual thing that's going to take place, and not to be scared if that dose goes up, because when you first start medication, you're typically at a subclinical dose. You're at a dose that isn't even really in the range of where improvement's going to be seen. And that's just to see if you have side effects. And your doctor is going to monitor that with you. And then after 10 days or 2 weeks, you're going to double the dose, and not to get too scared about that, right? And then you're going to wait a couple weeks until you hit max effect. So this isn't something that you're going to take it, you're going to feel better. Not an SSRI, at least.
Another myth there, Brooke, that you touch on, and you raise a great point there. But another one is when people will say, well, I'm thinking of going on some medication and my my good friend takes Wellbutrin, so I'm going to do that, and that's going to work for me. Or I don't want to take Prozac because that made my brother gain 30 pounds or something like that, right? The big mysterious component to specifically, especially psychiatric medication, is that the impact has to do with your own body chemistry, and the results can vary greatly from person to person. What the side effects might be, what the benefits might be, if there are drawbacks to it. And so it's really common for people who are taking, say, an SSRI, a depression medication, to have to try 2 or 3 different ones before they find one that works for them.
Exactly.
And so, yes, that also takes a long period of time because you're going through the gradual ramping up, and that can take weeks to months.
Yeah, which is also why there's specialists for this. There are psychiatrists for this, because they're going to understand that chemistry way better than what we will as therapists, right?
Sure.
Yeah, no,
sure.
I agree.
But as therapists also, we, have the unique experience of being able to see them kind of in the snapshot every week or however often seeing us, and kind of see what the changes might be over that course of time, and maybe feed that back to the client for, as our observation. Like, you look like you're feeling better this week. You're a little brighter,
Yeah,
your face, you're smiling a little bigger, whatever that might be.
Yeah, your eyes are brighter, right? They're more open. And another myth that my clients seem to, or what I notice is they want to go on it for short term. Like they want to go on it for a short period of time.
Yeah.
So just kind of explaining a short period of time for these SSRIs is probably 6 months to a year.
Yeah.
So I think sometimes people, when they're thinking about taking the medications, they think they're going to take it for 2 weeks. And then they're going to feel better. You're going to go off it. But going on medication is a bit more of a process, just with that build up, trying to find the right one, and then safely going off the medication with assistance of your physician. The whole process, start to finish, might take a year.
You are. Yes. Been trying out several different ones and all of that. That might take quite some time.
Yeah.
So when I say it can be a quick fix, like like flipping a switch, I guess I'm speaking relatively, meaning, it could be for some folks, within a month or so, they could be feeling a lot better. But for many folks, that does take quite a bit longer.
And just to always, if you're wanting to stop them for whatever reason, just do so under the guidance of your doctor. I think stopping medications cold turkey is not recommended. And there could be quite adverse kind of side effects of that. So just always kind of consult.
Yeah.
Very true.
Yeah.
Very true.
With this, one area that I see that this seems to happen quite quickly, improvement from medication, although it's not actually from taking the medication, the placebo effect of having Ativan when you're on a plane, if you're anxious to go on plane rides.
You're saying just having it with you.
Just having it with you seems to reduce, without actually even taking one, seems to reduce the anxiety. In what I've heard from many clients, just having it with them will totally prevent a panic attack on a plane for them.
Yeah.
Interesting.
That's true. Yeah, having it. I've heard the same thing. It's like a safety net there. Gives them a sense of safety, security, yeah. But also just, if you look at the research too, a lot of people take medications with the expectation that it's going to give them a boost. So the wider placebo effect too, when it comes to medication, has been studied as well, right?
Certainly. When you were talking, Brooke, about something having an immediate effect, I actually then remembered a whole other branch of medications, which is ADHD medications, right?
Yes.
So Ritalin and some of the other partners out there, for people who are struggling with ADHD, they can take that, and it's short acting and quick acting medication. They'll take that in the morning and they'll feel great, feel more focused and better able to pay attention within a couple hours. So that has but they kind of need to take it on a regular basis, because it doesn't build up in your system. It goes It's short acting, short half-life.
Mhm.
So, okay, so medications. Will you guys? How do you talk to your clients about medications? Like, if you notice someone is highly anxious, and you've kind of worked through a lot of your kind of go-to anxiety treatments, will you talk to them about medication, or how do you go about this as their psychotherapist?
Oh, that's a good question. I actually start that topic or conversation on day one,
Mm.
because on the intake I do ask if they're currently taking any medications, and whether that be psychotropic medication or whether that's any other medication, right? So it's already on there, or their history of taking it. So clients are typically pretty open about that. And if they say, no, I've never been on a medication for this, then I do ask their opinion on it, not to sway them one way or another, but just to get a temperature check from them on where you at with how open you are and what's your values and beliefs around this, because you have to meet the client where they're at and where they're comfortable. So if a client says, no, I've never been on them and I don't want to, then I'm aware of that. And I know in the future, if I need to bring it up, it's done very gingerly. So, yeah. So if it is something, then that might be I know that we've talked about this before, but I'm wondering, maybe you would be more open to looking into medication. Is that something, we've done all these things, you're finding it challenging? I can explain how medication works a little bit.
You could draw a diagram
I
of
was just gonna say that.
synapse and the little serotonins going back and forth, right?
Sure can. Chris, are you looking for it right now? It's on a yellow sticky note.
Oh man.
I don't see it here.
For those who are just
Might be in
listening
the
and not
drawer.
viewing,
Everywhere. Where?
In a drawer. The main big drawer, or the one?
Drawers?
Yeah, there's drawers.
this is great
You
listening.
have to give me a few moments to find it here. But
Brooke had a drawing that she showed us a few weeks ago, so maybe that was the inspiration for this talk here today, huh, Brooke?
Yeah. I think the other one would have been really straining for our brains. I had another topic. Maybe I'll save it for next time.
Okay.
Yeah, I like your approach there, Brooke, and I think I do elements of that as well. I was trying to gauge their perspective of it and gather information. Of course, I don't offer I'm just curious whether it's working for them, and I think every option is usually on the table when it comes to helping someone with their mental health. And ideally, often collaborate with their doctor or psychiatrist and work together and see if we can help them. So I think that's often very beneficial.
So there's been, do we have it here?
I found it.
So now you gotta go to YouTube to look
There's
at
a
this.
reason to go to YouTube.
Oh, there we go. Perfect.
Okay, Brooke, can you explain this diagram for us, please?
Well, it's not going to be very fun for the people that can't see it, though.
Well, this is a reason for them to go to YouTube, I guess.
Well, it's going to be hard. Oh, it looks really bad. Oh my gosh, you guys just got to go to YouTube. Anyways, so this is ascending neuron and then a receiving neuron. And what happens is an electrical transmission goes down. That's the arrow, is an electrical transmission going down. And then there's a receptor site that sends a neurotransmitter across an area called the synapse, which connects into another receptor site on the receiving neuron and sends the message down. So, and every neurotransmitter has a different shape. So this has triangles and squares and circles. So in this example, the SSRI, we're going to work with serotonin, is the little triangle. So the triangle goes across and connects into the receptor, sends a signal. Once it sent the signal, it has to travel back across the synapse, and then it reconnects into a receptor type. And that's called reuptake. So medication, where the little X is, the X represents the medication blocking that receptor site. So when serotonin tries to go home, it can't. And so it bounces back off, goes through the synapse and reconnects to the other side, sending another signal. So the medication doesn't give you more serotonin, it just makes your serotonin work harder. But this diagram apparently is kind of funny looking.
No,
Funny looking, Ryan and Joanna.
let me just say that I think this diagram shows that at heart you're really a Freudian,
Yeah, I was just thinking that.
because it looks a little phallic to me. I don't know,
Just a little bit.
Could be
bit,
mushrooms.
right?
Could be.
Could be. That's a whole other story. So yes, thank you, Brooke, for that description of the SSRI, the selective serotonin reuptake inhibitor, right?
Yeah.
Yeah, very educational. That's good.
It's good.
A
I would
question.
like to see all of you guys draw that now.
Okay.
I'd literally draw
Challenge.
it exactly as you did it.
I used to draw those in my textbooks back in high school.
I can't really draw it, Brooke, but I tell you, I have dreams about that sometimes. I don't know. That's great.
That's good.
Funny.
Of course you would, Ryan, being the the Freudian psychologist there. That's good.
The
Well.
psychoanalyst. Yeah.
Yeah.
Psychoanalyst, yeah. I lost my train of thought there. Oh yeah, my question. So in psychology right now, they're doing a lot of testing on other types of drugs to impact people. So for instance, to help with pain and a whole bunch of other things, including anxiety, there's CBD that's being given to patients, especially up here in Canada. It's being, I'm sure down there too, Ryan. They're also doing for addiction, ayahuasca. So we have Gabor Mate, who specializes in one of our addiction experts in Vancouver, and he'll actually take clients and hook them up with this type of treatment. It's still kind of controversial and still gathering some data, but I've had some clients who've done that before and they felt it was life-changing and part of the solution in terms of ending their substance use.
Yeah, I have a few peers from way back in my master's who are now, I think there's 2 from my cohort that are doing training in the use of psychedelic drugs in treatment.
Yeah.
So it's interesting.
Yes. I interviewed a fellow by the name of Michael Mithofer for the Psychotherapy Networker who uses MDMA for trauma treatment.
That's right. Yeah.
Fascinating work that's being done there. I mean, this is like one time or maybe a couple times. We're not talking about the same thing as SSRIs where it's, a daily pill. This is a specific treatment where you are doing basically with his system. It's like an 8-hour therapy session, and you're given a dose of this very strong kind of psychedelic drug, and then you kind of process through your trauma. The belief is that, or what they find is that people are able to go through and discuss their trauma at a distance, because the drug kind of helps them see things, that kind of out of body experience in a way, so they can see their traumatic experience and kind of empathize with themselves in a different way. Of course, a lot of training goes into this, and he's a medical doctor. There always has to be a medical doctor nearby, but it's a big deal in psychotherapy these days. People are looking at psychedelics of all sorts. Psilocybin, MDMA, ketamine is a big one. I've seen a lot of folks taking ketamine right now, and that's for some been very helpful for their depression symptoms. So yeah, it's a big field.
Yeah, so I think they're trying to standardize it a bit and trying to gather some research and trying to do it in a very safe way. But some interesting results so far, right?
Yeah. Also, to speak out of the other side of my mouth, there's also been criticism of medication, that people are kind of being over medicated in the U.S. at least. I don't know what you guys have up there, but oftentimes, 30 years ago, if people had a problem, they would first go to either a therapist or like a religious leader or someone, a trusted person, maybe their medical doctor, to talk about what was going on, try to find some other solution. But now the first place that people often go is to their primary care physician and say, I'm anxious, please, can you give me something? And they go kind of straight to medication. And that's unfortunate. I'm thinking my bias is that that's unfortunate because again, medication doesn't teach you anything, and there's kind of a lot lost there. And what research has shown is that it's actually for someone who's got some significant issues going on, it's the combination of medication and psychotherapy that's the most beneficial.
Mm-hmm.
Yeah. Yeah, for sure. Often encourage people just to educate yourself as much as you can on the medication. Sometimes a lot of the prescriptions come from GPs and family doctors, and often they have such a short amount of time to connect with patients. Not always the case, and I don't want to make any assumptions here, but often they provide a lot of material to patients, so I really encourage them to look at it and research it and the side effects as well, right?
Yes. Potential side effects, right.
Potential side effects, yeah.
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 Hmm.
Yeah.
So to complete Brooke's question here, is there a time when you feel medication's unhelpful? We talked about a lot of ways that it might be helpful, but when might it be unhelpful, if at all?
Again, it's kind of tricky to comment because I'm not as well versed in this as a psychiatrist or doctor, of course. But
Yeah.
if a client is noticing some intensive side effects, then or if it's impacting their ability to sleep and eat and some of those essential aspects of well-being, then I'd encourage them to follow up with their doctor. And or if I had a genuine concern and I thought it might be medication related, I may just not. I wouldn't share my comments with the client directly, but I may call the doctor and just discuss the concerns, and maybe they can educate me on it or talk about that a bit more in depth.
And it's not uncommon too that we hear some people say that they've tried out multiple antidepressants or things like that. So some, different people might work better with different drugs. So there's that too, finding one that's most appropriate for them. But again, I'm not a professional in that way. So it's just more, I just hear that more, that people are like, yeah, this one wasn't working for me, so I've weaned off it and gone on a different one. And so that's not uncommon.
Yeah.
Mm-hmm.
I used to work at a detox, and we had a integrative team. So I was a therapist there, and then we had a medical doctors and nurses and stuff. And often people present with a lot of opiate addiction and addiction to benzodiazepine as well. So I'm not saying that they are addictive, but sometimes they can be a little more addictive from the other ones and need some assistance and help to properly wean off of them, or to switch to a more appropriate medication that's a little safer. So those are usually two that pop into my mind, is benzodiazepines and opiates, to again educate yourself, and it could be very much beneficial in terms of your treatment, but there can also be some concerns.
I would just add to that I think there are some times when people may be going through, maybe experiencing some emotions that are pretty normal and necessary, and they feel that maybe they need to medicate that instead. And we actually talked about this when we were talking about grief several episodes ago. And my belief is that, I know that grief is uncomfortable and painful, but I believe it's a necessary process we have to go through, not a problem to be necessarily medicated. And certainly there are a lot of degrees of this, and someone experiencing debilitating grief to the point where they can't even function, then yeah, medication may be the right option. But if you're just feeling some discomfort about some things, a loss, feeling some kind of normal anxiety that someone might feel on a first date or something like that, we don't need to medicate all of our feelings. And I think, sadly, I think some of our society, at least here, kind of believes that, oh, you're feeling something uncomfortable, well, we've got a medication for that, or here's something you could do to take that away. And I think that's unfortunate, because I think there's some things, like I say, that it's good for our character, and I think actually part of our healing process to be able to feel some of those feelings.
Mm-hmm. I agree. Also, an unhealthy, well, not necessarily unhelpful, but it might be a point of conversation with a client for me. If they've been on a medication for a while, by a while, I mean 6 months or a year or longer, and there's symptoms, they're reporting symptoms that are similar to when they started the medication. So if there doesn't seem to be much of a difference, because sometimes we'll just get in the habit, not saying that medication can't be helpful for that person, but maybe that means it's time to go to the doctor and do a reassessment of, is this the right one? Is this working? Where was I when I started? Where am I now? Just like starting that conversation a bit.
Yeah, it's good. That's a good question. Good point. Yes.
Yeah.
Kind of a reevaluation.
Mm-hmm.
Well, you guys, we have medicated ourselves to the end of our episode here. We're all the way there. I hope our voices have been as soothing as Xanax and and other benzos, right?
Our outro music should be Prozac, the band Prozac.
Oh, there you go.
What did Joanna say, that Ryan's voice is like the Morgan Freeman of mental health boot camps? When he was doing that mindfulness?
Yes.
Or podcast,
Yeah.
There we go. Okay. A little anxiety reduction there, hopefully.
A dose of rye guy. Just a little dose of Ryan.
Oh boy. Oh boy. All right. So that's it, everybody. Like and subscribe on Apple, Google, Podbean, or YouTube. Send your questions to us at info@mentalhealthbootcamp.com. Visit us on Facebook or Instagram. Tell a friend, and come take a look at YouTube at the great drawing. Yes, perfect, Brooke. Way to go. All right, you guys. Had a lot of fun. Have a good night.
Bye.
See you later, everybody.
Bye.
Bye.
Bye now.